this meeting as well. So this meeting is being recorded, and the intent is for, excuse me, the intent is for the meeting recording, PowerPoint, any handouts to be shared on the HCA SERI webpage. And that link is shared there. Excuse me, I don't know why that's popping up. And the meeting recording and documents are going to be open to public disclosure. So with that, please do not disclose any private or confidential information. As this is a teaching webinar, there will be no formal roll call, but please feel free to introduce yourself in the chat. Typically, that is going to be during the question and answer time frame that we've set aside. So you can definitely put questions in the chat throughout the webinar, but we do have a set aside time for that. So we may not get to them while we're presenting, but we will absolutely get to them. So what are our objectives and what is the intent? So the intent of this webinar is to offer orientation to our Washington state plan and how it applies to our behavioral health billing and encountering guidance for Medicaid, and to discuss our differences and our similarities of the service encounter reporting instructions, which from here on out I will refer to as SERI. So if you have an iPhone, you might want to mute it. Or move it, excuse me, so it doesn't continue to talk back to me. The mental health billing guide and the substance use disorder billing guide. And then we're gonna look at how we review changes to those guidance documents and those billing guides. And so what are the objectives, or what is the intent? What is not the intent of this webinar? So it's not to provide direction on how to bill or encounter. So providers should refer to their individual BHASO or MCO contracts for billing direction. Again, you may get the same kind of parting line of, we cannot tell you how to bill, but nonetheless, the guidance and that direction should be outlined within those contracts. We at HCA are not going to provide that. If the individual client is assigned to an MCO or BHASO funded, that's where you're going to get the most guidance, is within those contracts for your agencies. And it is not to address any specific questions or concerns or provide technical assistance, as this is meant to be a broader kind of forum and to address overview of these elements. All right, so what is the foundational elements of Medicaid? That's where we're gonna first go to with this. So what is the Medicaid state plan? So it's basically HCA's contract with the federal government. So it's required under Section 1902 of the Social Security Act that we have a state plan. And that is our official description of what we have of our programs that use Medicaid funds. So it outlines kind of the nature of the programs, the scope of the programs that use those federal Medicaid funds. So without a state plan, we couldn't have that federal funding to provide those programs. So our state plan is the agreement that will conform to those requirements, and that we will conform to it, and that we will conform to that oversight by DHHS, which is the United States Department of Health and Human Services. And it's important to note that when we say Washington Apple Health, it means the public health insurance programs for eligible Washington residents. So this is Washington Apple Health is the name used for Washington State Medicaid, CHIP, which is the Children's Health Insurance Program, and then also the state-only funded healthcare programs. So wanted to just also outline those elements all encompass Washington Apple Health. And one of the departments, if you will, of the United States Department of Health and Human Services that you all may be very familiar with is CMS. And you'll hear that a lot throughout kind of our discussion here. And then you likely hear that throughout your own internal discussions at your agencies or otherwise. This is a very, very, very bird's eye view of what is considered mandatory Medicaid services. So this is not all of the mandatory Medicaid services. This is a very, this is a snippet of mandatory Medicaid services. So these services are within our state plan, and we are required as a state to have them. And so we do. We have these outlined in various sections of our state plan, and they are funded by Medicaid dollars. And then we have something called optional Medicaid services. So we, as the name outlines, we can choose as a state what services we want to opt into as part of our Medicaid benefit. And the two services that we have chosen to opt, well, not the only two, but the two services, the two areas that we're going to be focusing on today, or the two sections that we're going to be focusing on today, are highlighted on the screen as the other diagnostic, screening, preventative, and rehabilitation services, and the other practitioner services. And I'm going to turn it over to Yvonne to explain what those are.
So our behavioral health agencies lie under 13D of our state plan, are rehabilitative services. And rehabilitative services outlines how substance use disorder, problem gambling, mental health services are provided within a behavioral health agency, and how they can be billed directly to HCA or encountered as a Medicaid service. Next slide, please. And then our other practitioner services, 6D of the state plan, is our other practitioners, and it outlines how substance use disorder, which we just recently added last year, and mental health services are provided by DOH credentialed practitioners, are approved and approved by Medicaid to provide services. Next slide, please.
All right. It's time for some trivia. So with this, you can put your answer in the chat. We HCA colleagues, you can absolutely participate. We also would like to see where our community providers are, even our MCO partners, BHASO partners, just anybody. Feel free to put it in the chat and let's see where everybody kind of stands. So this is going to be based on what we just presented on. And let's see where we go from here. So the first question is, what does SPA stand for? What do we have popping up in the chat there?
State plan amendment. Good job, Anna, Jennifer, Sandy, Jane.
State plan amendment. State plan amendment, yes. And we'll take it one step further if someone wants to speak up on that. What is the state plan amendment? One sentence or less. Well, one sentence.
And Janie.
It is our agreement with who?
We have an agreement between HCA and the federal government, CMS.
Yes.
Yes.
CMS. Who gets that gold star?
I'm gonna give it to Penny Beeson.
Awesome.
Thank you, Penny.
All right. Thank you. Next question. True or false? All Medicaid services are required to be covered.
False, false, false. We got a lot of falses.
False.
Oh, we got a true.
Oh, there was a true. So let's,
Yeah.
so that can be, it can be a little tricky, right? So the way we worded it was kind of so we could have a discussion, but we also, we're going to say no. Some are optional, right? Such as the 6D and 13D that we outlined. So we said no because there was the optional services and then the mandatory services. But of course, if we do choose to opt in, then they do need to be covered, right? But if they are mandatory, then they absolutely need to be covered. But when we said no, we meant because of the 6D, the other practitioner services, and 13D, the rehabilitative services. So those are the optional behavioral health services that we as Washington State have, we optionally have chosen to cover. Any question? Does that make sense there? All right. Last question. The state plan is Washington's agreement with the U.S. Department of Health and Human Services. I should have made, what do we got there for the answers?
I'm not seeing anything. Oh, true. We got true, true, true. We got some trues, got some T's. Courage to change. Good job.
Perfect. I should have made that a little trickier. I should have put a different word in there somewhere to mix it up a little bit. All right. So it looks like we got the part of the state plan kind of nailed down. So that's kind of the foundational elements that we want to move forward with. So keeping section 6D and 13D in mind. We're going to move forward with that in mind to the orientation of SERI. So SERI is, again, the service encounter reporting instructions. Oftentimes when people talk about SERI, they think it is a billing guide. It is a guidance document, not a billing guide, and it is an encounters guidance document. So it's an instruction manual for reporting the behavioral health service encounters, and it correlates to the state plan section 13D. And it has to do with the encounters that are required to be reported by both HCA contracts with managed care organizations and behavioral health service organizations. So what is SERI? So SERI outlines the requirements and timelines for reporting. So it offers the type of clinical service provided, the billing codes that represent that type of service, how to report that type of service, such as the number of units or minutes that are allowable, when and how to denote that program information. So was the service a part of a specific program? So for instance, WISE is in there, PACT is in there, New Journeys is in there. And what are the allowable provider types for each service? So for example, what services can be provided by an LMHC, so licensed mental health counselor, versus a certified peer counselor, now called a certified peer support specialist. And we really want to note and call out here that listed taxonomies in SERI are not the only provider taxonomies that are allowable. For example, there are subspecialty taxonomies that would be allowable. For example, I believe under psychologists, there are 9 other subspecialties that would be allowable. We don't list all 9 taxonomies, but psychologists are allowable provider types. So we list the main one that is through what's called the NUCC, which is the main oversight nationally for provider types. And so some taxonomies included in SERI are local to Washington HCA and are not federally recognized. And so that's important to note. And we do include a document, and you're going to see links throughout this presentation, like how to register an NPI. You will have all of these provided to you. We have a resource document that is going to have all of these links provided to you. So you will not be without. So what is SERI? Is it Medicaid or not? So SERI actually is both. SERI again is meant to provide all encounters on all of behavioral health. SERI is meant to show where there may or may not be gaps in services by providing the behavioral health data to show that. That's what encounters are meant to do. So we want to show all of the non-Medicaid behavioral health services that are being provided, as well as the Medicaid services that are being provided. So the Medicaid services, again, are determined by the state plan, that's section 13D, for both mental health and substance use disorders. And they're described in this section, Medicaid allowable services. So in SERI, we really try and outline and break it down by sections. These services are medically necessary and they're covered by allowable provider types, and they follow the guidance and the duration as listed and outlined in SERI. And then there's the non-Medicaid services. That's also broken down and outlined by the titling of other services sections in SERI. And they're also to be medically necessary and covered by an allowable provider type and taxonomy and follow the same duration and guidelines. So again, SERI is both Medicaid and non-Medicaid behavioral health services, as it is meant to be a guidance document for behavioral health data encounters. So we then address who should use SERI. Behavioral health agencies licensed by Department of Health. This would include federally qualified health centers, or FQHCs, who are also licensed as behavioral health agencies, who provide mental health and or substance use disorder services, who contract with managed care organizations to provide those services to Medicaid enrollees. And so they would be providing services that would fall under the services outlined in the state plan, which is again that section 13D, rehabilitative services. And they would also, or could potentially also, contract with BHASOs, or behavioral health administrative service organizations, to provide mobile crisis outreach, for example. So the requirement to use SERI should be specified within the provider's contract with the MCO or BHASO. So when is SERI published? I hold a SERI work group on a monthly cadence, and it includes HCA partners from all divisions, as well as MCOs and BHASOs. During these work groups, we address kind of changes being made to the SERI, and we aim to vet them prior to publication. And contractually, HCA is required to provide a 90-day notice to MCOs and BHASOs, who then we ask to notify providers. And our goal is always to publish on like April 1st for a July 1 implementation, October 1st for a January 1 implementation, so twice per year, with interim guidance published as necessary. Occasionally, we are not able to give a full 90-day notice. This happens where we may not be given a full 90-day notice. This can happen when the American Medical Association, or AMA, releases what's called CPT code set changes. This can typically happen November, December, and then they have to be implemented by January 1st. That unfortunately is out of our control. If they discontinue a code, we don't have a choice. We have to discontinue that code. So we can't always have control over that 90-day notice, but when we can, we absolutely aim for that. Any recent SERI changes? we always encourage to look for the summary of changes page at the end of a full SERI publication. So interim guidance is usually some recent changes. Usually it's legislatively driven or code changes that we need to publish in between those April 1st or October dates. And so the full versions have, which are the April 1st and October publication dates, we have a summary of changes page at the end of the document, and it tells you what changed, why, and where it can be found. And that's what we really encourage everyone to look at, and what we encourage everyone to review with their agencies or MCOs or BHASOs. And again, all these links will be provided to you, as this is where you can find current and historical documents. We also encourage everyone to sign up for Gov delivery notifications. It's likely how you got this notification that there was the SERI webinar. This is our second one this year. And the link is here to be able to do so. So you'll also have access to this link. And more trivia time. So these are going to be true and false questions, and they're going to be about SERI. So let's see what we've learned. So true or false? The requirement to use SERI should be specified in the provider's contract with the MCO or BHASO.
Yeah, a lot of trues. Oh, Mike's not allowed to vote. True, 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 true. Trues.
Trues.
A lot of trues. Yep.
A lot of trues. Perfect.
Yep. Good job. Oh, your trues backwards.
Whose is?
Oh, there it goes. I wonder why it was backwards. It must have, my computer must have lagged.
SERI, because I did a fun little animation there.
That's
SERI
right.
is not a billing guide.
True, 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 true.
Okay, so
True,
a lot of
Sandy.
true. So if it's,
true says,
so if it's
Sandy
not a
Foley
billing
says
guide,
true. Sandy Foley says true instructional. It's a guidance.
so
Cara Panic says
instructional.
true. It's a guidance document.
Yes,
Good
thank
job,
you,
Cara.
Cara. It's a guidance document. What is it guidance for? What are we trying to get from it? Anybody? Anybody? What do we want SERI to provide us with? Starts with a D.
We have encounter data.
Yes, yes. Who gets the gold star for that?
Oh, we have Sandy, Amy.
Amy from?
Starkey, Amy, where are you from?
That's okay.
Tacoma.
We can.
Amy's from Tacoma.
Tacoma.
Thank you, Amy.
Wonderful. Thank you, Amy. Yes. Good job. All right.
Comprehensive
True or
life
false? Ooh, this one I didn't directly address, but let's see if it can be kind of assumed from what was outlined. SERI has its own fee schedule. True or false?
Courage Change says false. Getting a lot of falses. False. The specialized, nope. Somebody said the specialized mental health fee schedule.
All right. So I got some falses and then the specialized mental health fee schedule. So there is not a fee. SERI is not connected to a fee schedule. The specialized mental health fee schedule is not connected to SERI. We will go over that later on. SERI does not have a fee schedule. The reason for that is that if you are using SERI, it means that you have a contract with the MCOs or BHASOs. The specialized fee schedule is a contract with HCA. So your fee for services that you are contracted with the MCOs or or BHASOs, specifically with the MCOs, your fees are negotiated with them, not with, and so therefore that fee schedule is not published through HCA. So the specialized fee schedule does not apply with SERI. So no fee schedule attached to SERI because it is not a billing guide. So no fee schedule attached to SERI. That would be determined by your contract and during negotiations for those services. All right. Moving forward, Yvonne.
So this is our orientation to the mental health billing guides and SUD billing guide. So what is the mental health billing guide? So our mental health billing guide has 4 sections, but we're gonna focus on part 1 and part 2 for this webinar. So part 1 is our billing guides for mental health outpatient and inpatient psychiatric professional services provided by our independent practitioners and clinics to bill Medicaid. And this section correlates to 60 of the state plan. Part 2 is our billing guidance for our licensed behavioral health agency who see Apple Health clients without a managed care plan. And this section correlates and provides services to 13D of the state plan. Part 1 and Part 2 are our Medicaid programs. So for Part 2, you'll see Medicaid services, but some services are not in there that are in SERI because of the Medicaid element. Like PACT. PACT is a non-Medicaid mix. It's mostly non-Medicaid. So there was no way to bring it over to Part 2 services. So that's why you'll see some services not there, is because of the non-Medicaid element in that. And the mental health billing guide and part 1 and part 2 follow CCI edits. We follow federal law with those, so you'll see some differences there. Next slide, please. The substance use billing guide is for licensed behavioral health agency who see Apple Health clients without a managed care plan, and this also correlates and provides services to 13D of the state plan. Also the same thing as a Medicaid program. So the services you see there are approved by CMS, and so it follows those guidelines. Next slide, please. When are the mental health and SUD billing guides published? They're published quarterly. Prior to publication, you'll see HCA works internally to address changes and reviews for the changes, and then you will find the quarterly updates updated at this link. And so you always want to go to the current time frame that you're billing for. So if I was billing for July, I'd want to go to the July 1 updates and make sure I'm following that quarter for information. Next slide, please. Always look at the what has changed table. That will give you the most current information, and our billing writers work really hard to make sure that those links right to the billing guide, so you don't have to go find it. So if you click on that link, it'll take you right there, so you don't have to search around. And also current and historical versions of the document are also found at this link. So like I said, if you're billing for the time frame you're billing, you always want to go to that billing guide. And then also you can sign up for billing guide and notifications by going to the Gov Delivery at this link. So this is for tribal providers, and our tribal providers, our OTA folks, and our FQHC partners, while they use our billing guides, use mental health part 1, part 2, and SUD as a parent guide, they also have their own billing guides that are in alignment with what they do. And so you want to go to the same place that the mental health and SUD billing guides are for a tribal health program billing guide. Tribal providers enroll with their own billing taxonomy for part 1, part 2, and SUD. they have, and these are the taxonomies that they enroll with and use for billing. Next slide, please. Rural health clinics and FQHCs. We have some FQHCs that are licensed as behavioral health agencies, so they would use SERI for encounter reporting and the appropriate mental health Part 2 or SUD guide. Non-FQHCs use Part 1 of the billing guide. So it's very important for that distinction of what parts of the guide to use. And so FQHCs would use that are licensed as behavioral health agencies would use Part 2 and the SUD billing guide. And for RHCs who are clinics, you would use Part 1. Next slide, please. You know it, more trivia time, true or false? Mental Health Billing Guide Part 1 is for specialized mental health services. Boris, good job. False. Nope. Seeing a lot of falses. That is false. Yes, the specialized mental health services fee schedule is for mental health Part 2 for our behavioral health agencies. So you're correct when you say no. Good job. The SUD billing guide and mental health Part 2 reflect 13D of the state plan. Good job, Kaylee. True, true, yes. Sandy said no. This is true. The SUD billing guide and mental health Part 2 do reflect 13D of the state plan. And we crosswalk kind of to SERI, but like I said, some of the services you find in SERI would not be because of the non-Medicaid. Sorry, Sandy. Would not be in the billing guides because these billing guides are a Medicaid program. FQHCs, RHCs, and tribal providers do not have their own billing guides. Mike knows this one. False. Yes, that's all. You are all correct. False. Yes, they do have their own billing guides. They use Mental Health Part 2, Part 1, and SUD billing guides as their parent guides, but they do have their own program elements and their own billing guides. So good job. And this is the orientation to the Encounter Data Reporting Guide. I'll answer Louisa's question really quick so it doesn't get full. So Louisa, the reason why there is no PACT in the mental health, specialized mental health billing guide is because of the non-Medicaid, non-Medicaid mix. It was mostly non-Medicaid. So the BHASOs get our PACT funding because it was mostly non-Medicaid and it was very difficult to pull that apart. So the BHASOs get the PACT funding for that service. Okay, so Encounter Data Reporting Guide. So this reporting guide is for MTOs and BHASOs. It is a reference tool that outlines how to transmit encounter data to HCA's Provider One payment system. HCA created this reporting guide to use in combination with the standard 835, 837, and National Council for Prescription Drug Programs. And one encounter guides. The information in this encounter data report is not intended for change or alter the meaning or intent of any implementation specifics of standard implementation guide. Well, that's a lot. So I know enough about this to make me nervous. So next slide, please. When is the Encounter Data Guide reporting published? It is published periodically. Prior to publishing, there are internal HCA work groups to adjust changes and opportunity to review. And you always look for the what has changed in the beginning of the document for a quick reference to what has changed. And to review the EDRG, this is a link to the data Encounter Data Reporting Guide. So this is how the data comes into us, and these are the required elements that need to be in place.
Perfect. All right, and here is the final round of trivia, and this is kind of going to be a mix of potentially everything or maybe some new stuff, and let's just kind of see where we're at, and it's going to be true and false. So HCPC codes are meant for Medicaid and Medicare services. So we didn't talk a lot about codes, but they do exist in all of our guidance documents and billing guides.
Oh, getting some true, getting some false.
Oh, we got a lot of we got some mixed
Yeah.
stuff. So HCPC codes are both. They are Medicare, Medicaid, and Medicare services. And we specifically like the level, what's called level 2 HCPC codes are a lot of what you see for behavioral health codes that are chosen to represent the behavioral health services that you see in our guidance documents, that represent the services that that represent the services for 13D 13D state plan services.
I'll use an example. Connie, it is the tricky question. I'll give an example of this. So our OTPs for Medicare, they use G codes.
That's a great one.
And so
they do.
We have, yes, and so we have, for those OTPs, we have the G codes open, so they cross over to us. And we want our OTPs to be registered with Medicare so that when Medicare clients need OTP, they bill Medicare first, and then those G codes come over to us. Yes, G codes for yes. Thank you. Yes.
Yep, exactly. Yep, G codes for OTP. Yep, Andrea got that. I noticed someone's said for all medical billing. I think that was meant for the Medicare piece of that.
Yeah, well, I'll use behavioral health also as an example for for licensed mental health, there are CPT codes that will cross over for our licensed mental health clinicians that Medicare accepts. So those would also cross over. But those are CPTs, so I didn't know.
Yeah,
not HCPC.
Yeah, not HCPC. Okay. Peer support is a service, and therefore certified peer support specialists and certified peer support specialist trainee provider types or providers would be listed providers in SERI, the Mental Health Billing Guide Part 2, and the SUD Billing Guide. True, 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 true. True, 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 true. Yes. What if I had said that they are in the Mental Health Billing Guide Part 1 and therefore included in the state plan 6D? What would the answer have been? Yes. Correct. Correct. It would have been false. They're currently not a provider type in our peer support is currently not a service within 60 services of our state plan. So they're not currently within clinics at this time, but they are provider types within behavioral health agencies. So that would be correct. If I am a private practitioner, I should refer to SERI for my guidance. Okay, I see a true. I see a yes, 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 yes. All right. So I see yes, yes, yes. Don't see why not. Uh-oh. Okay, guys. No. The answer is no. False. Big false, actually. So if I am a private practitioner, it means that I am not a behavioral health agency. It's likely that I'm hanging my own shingle. I would be using the Mental Health Billing Guide Part 1. Does anybody know the reason for this?
I'm going to answer Tabitha's question saying they're not contracted with Medicaid. So private practitioners can have a core provider agreement with HCA and bill for mental health part 1. So if you hang your own shingle and you can contract both of the MCOs as a private practitioner, and you can also have a core provider agreement with HCA and bill out of mental health part 1. But yes, they're not a BHA.
They cannot be a BHA, right? So a private practitioner on their own cannot be a behavioral health agency, right? So therefore, you're not going to be submitting behavioral health in, yep, SERI is a BHA reporting encounter data, right? So that's why it's really important to remember what guidance we're looking at.
And I'm also
what
going
the
to,
purpose.
yeah, there's a comment about taxonomy question mark. Can you, I'm going to butcher your names, Maritini, can you come off mute and ask that question about taxonomy, please? Okay, well, I can connect with you later, but yeah.
Yep. So SERI
Yes.
is, what are you saying yes to, Yvonne?
She said taxonomy of practitioner. So yeah, so you could be a single, use the taxonomy for a practitioner. Yes. Yeah, for the specialty that they're doing.
Okay. Well, yeah. So I think when we're answering the questions, let's make them. I think let's make sure that we're spelling out kind of the whole answer to the full question, because I think I'm losing track as well as what's being answered and to what question. And so when we're saying taxonomy of the practitioner, meaning that they are a private practitioner, and they're master level and above, and it's the taxonomy of the practitioner, like as an LMHC. Are you talking about themselves as when you're saying taxonomy, what are you referring to, Yvonne?
So for behavioral health agencies, we have community mental health taxonomies that they use. Correct. And they're listed in SERI and mental health part 2. For private practitioners, yes. So you would build to the level of the master's level. So like marriage and family would use their practitioner, their unique taxonomy to their practice and what they're doing.
Yeah, does that make sense to everyone? So just wanted to make sure everyone was on the same page with what was being clarified there. All right, so yep, so if I'm a private practitioner, I should not refer to SERI for my guidance. If I use the mental health billing guide part 1, checking in SERI may confuse me. So I'm seeing some trues, true, 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 and that's true. It will. We've had a lot of questions come for people who are saying, well, it's different, you know, it's different in the billing guide than it is in SERI. Why is that? And that, or like it requires this in the billing guide, but it's not, it's different in SERI. And it's because there's different requirements based on which guidance, what the guidance is, or who you are and why you should be using it. And it's dependent upon when you should be using it, because maybe you have different contracts or different, like Yvonne was saying, you could have contracts with the MCOs and you could have a contract with HCA. Well, that means that you'd be using a billing guide for one purpose and you'd be using SERI for another. And so that would mean that there may be different guidance for those instances, but checking them against each other is going to confuse you, because they're going to mean different things in those instances. And while we do try and align as best we can, especially for the 13D elements, like the part 2 of the mental health billing guide and SERI, and the SUD billing guide and SERI, because that's all 13D, again, there is going to be elements that do not align because, again, SERI encompasses those non-Medicaid pieces. So that is correct. And I did see a question in here. What is the line for BHA versus single licensed practitioner who runs a clinic with 4 to 5 nurse employees? Naomi, do you mind expanding upon your question there?
Yeah, so I'm trying to, and I apologize, I'm an attorney, I'm not a provider, but I'm with Medicaid fraud control. So I deal with trying to figure this stuff out. I'm just trying to, because as you just stated, certain things are going to apply for SERI where they might not in other situations. So I want to know what that situation is. And I'm just admitting my ignorance here, where a behavioral health agency as opposed to a clinic, is there a difference? What's the definition?
The licensure type with Department of Health.
Okay, so it's a specific behavioral health agency license from the Department of Health.
Correct. Okay. Correct. Yep. And there's specific like service standards that have to be met. And the specialized, like the criteria, like for the specialized services that would need to be provided within a behavioral health agency indicate that it would be, you know, the term, it's become more of an archaic term now, as like higher acuity, but it is, you know, expected that clients with more specialized needs or a higher level of needs are being served in behavioral health agencies. That's why the specialized mental health fee schedule, for example, correlates to the, oh, Yvonne, what am I trying to say? The mental health billing guide part.
Two.
Yvonne, part 2, thank you. Part 2 I don't know why I draw a blank on that, but why it correlates to part 2, because it is for those specialized services. And so to become the service standard criteria does have expectations of the services that are to be provided within those agencies, and a clinic and a private practice agency is unlikely to meet those service standards and be able and serve that population in the way that it needs to be, that it as an agency could. And so that's why there is those licensures.
And Teresa and Anna did a good job in chat. Teresa put the WAC chapters for BHAs.
Yes.
And Anna also did a good job answering that they must be licensed as a BHA by DOH. So thank you for those resources.
Yes,
to
thank
both
you,
of you.
Teresa. Yeah.
And welcome, Teresa. We're glad to have you.
Yes.
And Anna
Teresa
also
was my mentor for all of this.
Yeah. And then Anna also put in a link to the BHAs down below. We do have a question in chat. Eliza,
I do see that. I do see that. So, and I see that we are going to get some questions. So we do have one more true or false. So peer support services is in 6D of the state plan. No, false.
Oh, Kiki.
False.
Forrest, nice
Good
to
job.
see you.
I see a dang on there. That we do I see 13G. Anna, thank you. It is in 13D, so we definitely appreciate that. And we are looking at 60 of the state plan and peer support. So more to come. And then oops, that went very fast, excuse me. What to provide when you send in inquiries related to SERI, the Mental Health Billing Guide, and SUD Billing Guide. We're going to provide you all a handout with all of this information on it. This is what we need. And when you send in inquiries, it's really important that you provide this information to us. Who are you? How are you licensed? So are you a BHA? Are you in private practice? Are you a clinic? Are you an RHC, an FQHC? Who are you contracted with? Is it us? Is it MCOs? What MCOs? Any specifics you can provide. Are you referring to SERI? Is it the Mental Health Billing Guide? Is it both? What services are you providing? SUD? Are you talking about group? Are you talking about IOP? And then what is your question? Any specifics you can provide us is going to help us answer your questions and as more thoroughly and likely quicker. And the way that it's going to get to myself and Yvonne more streamlined is if you send it via these links. For SERI, you can send it through this link and you can put in the subject line that it has to do with SERI, and it gets right to it. Well, it gets through our program mailbox and it can get assigned to me. And I really make it a point to try and respond as quickly as I can. I can't give you a set time frame on that, but my goal is to definitely be responsive to you all as a community. And for Yvonne, for mental health part 2, this is the link that we will give you. And then there is also a mental health part 1. We do have a colleague, Susan Matthey, who handles mental health part 1 and has been kind of learning the ropes from Yvonne and is now boots on the ground, and so is a part of the team here who's going to be manning mental health part 1. And then there also is the EDRG mailbox as well. And so with that, let's start answering these questions that you all have been posing. And I did see that the first one had to do with Recovery House and a clarification on, it looked like Recovery House Residential Services, code H2036, and it excludes room and board, yet the SUD billing guide indicates it is room and board. So this is where we really want to be cautious about comparing the two, right? So SUD billing guide indicates one thing, SERI indicates another. Yes, they are going to differ. And it says, is it intended to be used congruent with other clinical program codes as a room and board rate, or what is the HCA's expectation? Then what codes are expected to be used with it? So in SERI, room and board is paid for with non-Medicaid non-Medicaid dollars, and so we capture room and board separately. So we have a code that allows for that. It's H2036 with an HW modifier, so that it can be submitted. But the Recovery House itself is just submitted as is. It's assumed that the rate itself, well, I'm trying to see how a better way to explain that would be. Yvonne, do you want to explain maybe your SUD side?
Yeah, so for Recovery House for SUD, we have the
And yes, I will
H0018.
update the slide.
So we have the H0018 HF or the H0018 HA on the fee schedule. H2036 for fee for service is the room and board HCPC. And so they can be billed with the Recovery House together on the same day. The reason why room and board is separate is paid with state only dollars, and so that's our way of tracking that. And I believe in SERI H2036 is used a little differently, so we do, that is one place we do not have parity, and so you will see differences. But yes, and room and board can be billed separately from Recovery House.
Yes.
Mark, do you want to come off mute and ask for any more clarification?
Thank you. Yeah, I believe I captured everything you were mentioning. There was another different, the other code. There was the H2036. What was the other code you referenced?
Well, in fee for service for Recovery House, we use the H0018, HA or HF for adult or youth. And then H2036 can be billed separately on the same day to pay for the room and board.
And that's via the SERI versus via the mental health.
Yeah,
So,
SUD.
so
yes.
Mark, which do you refer to? Are you referring to SERI or the SUD guide?
I believe it was the SERI.
Okay, so for your agency, is that what you use? Do you use SERI or do you use the SUD guide?
We're actually MCO. So the question came up internally as how people are billing, because we get the question a lot ourselves.
Okay.
Or there's errored claims, so on and so forth. So that's the reason why I thought, well, let me ask or see any kind of a clarification while I'm here.
Okay. All right. So what additionally can we answer for you with that? Do you need something specific for SERI for the recovery house?
I don't believe so. I think you mentioned with the HW modifier, I think that kind of captures it. And
Yeah.
it's like you said, it can be billed separately. So as long as, we're seeing that or can let people know that, I think that's exactly what we're looking for. So thank you very much. Appreciate it.
Yeah, it's listed on page 122 of the current SERI. The room and board description.
Okay, that's helpful. Page 122?
Yep. Yep, and that's for behavioral health residential services.
Okay, thank you.
Yep, no problem. And then I saw the next question was regarding, will provisions be added to SERI for partial hospitalization programming to be covered under the substance use section and not just under the mental health section? Hi, Austin. So right now, partial hospitalization level 2.5, third edition ASAM is not something that is currently covered under our Washington State Plan substance use disorder section. This is something that is being looked at as we're looking at the implementation of the fourth edition of ASAM, especially with the high intensity outpatient services being looked into and seeing how we can potentially add that additional service. We currently, right now, what is available is partial hospitalization for mental health. That we sent out recently a clarifying FAQ that the IOP and the partial hospitalization that is outlined specifically within SERI is for mental health, and it does sit under the mental health treatment modalities within the SERI guidance and within the mental health billing guide. So right now, there is not intention for it to be added under SUD. There is not funding for that to be added currently, but it is not something that we are going to overlook as we have discussions about the fourth edition ASAM. We have gotten a lot of feedback both from providers and in discussions with our MCO partners about utility of partial hospitalization or the high intensity outpatient for the fourth edition. So that's more to come as far as applicability for substance use disorder. But right now, partial hospitalization is available for mental health only. Any additional questions on that front, Austin?
No, I think you've covered that pretty well.
Okay.
And is the time, I guess a follow-up would be, is the timeline going to be pretty similar with the date of implementation of ASAM 4?
Yes, unfortunately, we that date has been pushed out with the legislation to 2028 is what that implementation is looking at right now.
Okay.
All right. Are all the MCO systems configured to allow for the new DOH provider identifier on claims? Christy, that is a good question. That may be, I'm not sure that I can answer that. Yvonne, I don't know if you're able to, or if that would be a deferred to DOH question. Oh, and looks like Oh, it looks like it was answered. They are. So it looks like that one was answered by Jennifer. Thank you, Jennifer. Anna, help me understand, and IOP is not covered for mental health either at this point.
Well, I think you were saying that partial hospitalization 2.5 is covered for mental health.
So 2.5 ASAM, that's 2.5 is an ASAM that's specific to substance use disorder.
Okay, so but partial hospitalization, is that covered for mental health?
It is.
Yeah, okay. And then what about intensive outpatient services for mental health? Is that also covered?
Yep, it's actually been covered since 2024.
Okay, all right.
Yeah.
So it's just those two are not covered, and using the ASAM levels, they're not covered for SUD.
Well, so let's clarify, because they're separate levels of service on a continuum. So ASAM 2.5 represents partial hospitalization. ASAM 2.1 is IOP, or intensive outpatient. So there are different levels of care on ASAM. 2.1 IOP falls under outpatient SUD services, and outpatient SUD is covered and has been for a long time. So that's included within SERI under outpatient. That's been covered for a long time. It's not called out separately as here's intensive outpatient, other than in the description, we do identify ASAM 2.1, outpatient 1.0. Those are third edition ASAM levels of care. Those are outlined within SERI if you look under that modality specifically within SERI. When it comes to the mental health side of things, legislation was passed in 2023. We implemented it in 2024 for mental health intensive outpatient and mental health partial hospitalization. That was added into the service encounter reporting instructions guidance and the mental health billing guide as mental health services. So separate from ASAM and all of that, because it's a mental health service. And so there is mental health intensive outpatient service, and there's mental health partial hospitalization service. So those are also available, and they're also listed in SERI under the mental health service modality. Does that help?
Yes, thank you.
Yep.
So it looks like we have some entities having problems with the
I do see that. Are you talking about the G2? I do see that there's some, is that what you're referring to? Yvonne?
Yes, with the DOH.
I do see the DOH pieces, and I do see some specifics where we're having some callouts related to our specific MCOs. If we do have MCOs on the line, I do see a reference specifically to WellPoint. I would encourage your representation to take that back. Otherwise, we will take that offline and reach out to our MCO partners. Regarding, does HCA have an email list that notifies when SERI is updated? We do. We send out a gov delivery every time it's updated. So if you got the notice for this webinar, you would be getting the notices every time a SERI update is completed. If you do not, then if you did not get the notice for this update, then I would encourage you to go to that gov delivery link, which again, we're going to give you a resource sheet, and I would highly encourage you to sign up for those Gov deliveries. That's our email list for all behavioral health community providers, and that's how we get it out to you all. We also give it to our MCOs and our BHASOs, and we request that they send it out to their contracted providers. I do see a provider asking, what issues are you all having? Is the clearinghouse not accepting the claims and they are being rejected, denied by WellPoint? I would, anything relating to MCOs and providers, maybe could be taken kind of offline in collaboration, or HCA is happy to maybe help liaison some of those conversations. Again, we don't want to get really specific into technical assistance on this call.
Can I just chime in on that G2 segment issue real fast?
Who is speaking? Sorry.
My name's Austin. I had the
Austin,
question
yes,
earlier.
go ahead. Yes,
yeah,
please.
So like one of the issues we're running into is it's hard to get the configurations to work differently for like the separate payers. So we had to submit a special request to have our clearinghouse. It looks like a lot of other people are saying they also had to do this to get the clearinghouse to allow that segment to go through, because if there's certain information that matches, it automatically omits that segment. And so what we're running into is CHPW wouldn't process any claims without it. So we had that change done, but now WellPoint doesn't like that it's there. And so I don't think we can say, oh, send it for this payer, but not for this payer. That's where it gets difficult. So I don't know if anyone else is experiencing that as well. Just wanted to clarify that.
Oh, sorry, and I was referring to the DOH number, is that correct? Your example there?
I'm going to input the encounter companion guide and this change is in there, shared from Mike. Thank you, Mike. Hopefully it talks about the LUTSIM segments and who to contact for assistance. And then Liza and I can help maybe get this all together from if you put your name and email in chat if you're having problems with this issue and what MCOs. Yeah, we can streamline it and work and see what's going on where and what the problem is. So if you could yeah,
just put your name and email in the chat and put like G2 so that we know, so that we can send a general and then we can send a general inquiry to the MCOs. That would be helpful just for that inquiry, so we can take that offline. What you're seeing on screen is a reference table that you will have in a handout that we're going to email out to everyone. It's a kind of, we're hoping it can be kind of a shortcut reference point. It's that, it shows what guide and what part of the state plan is connected to, what providers would use it, and what clients it would apply to. Again, we're also going to be providing all of these resources so that you have them kind of at a quick, here's kind of a quick glance. And then again, resources continued. And we're hopefully going to intend to email this out to you by early next week at the latest. And we hope to get this all posted up onto the website as well with the recording. And otherwise, that comes kind of to the end of our presentation. Are there additional questions that we can offer to you all? Well, we don't have the questions. Are there additional answers that we can offer at this time? And we do hope that you all found it useful and informative and hopefully a little fun. We tried to break up some of the segments this time. And please definitely go and explore the SERI webpage and website and the mental health billing guide page and website. And we will get those resources out to you all and go from there. Thank you so much for joining.
Oh, the hand came up and then it went away. Okay.
That was a lot of work. You guys are awesome.
Thanks, Mike. Appreciate you.
We appreciate you being here.
Thank you.
Could you put up that last slide with your contact information? This is Margie.
What was that, Margie?
Could you put up that last slide with your contact information? I wanted to snap a picture of that.
Oh yeah, we're going to be sending it. We're going to be sending it to you all pretty